Today, we're going to be talking about women's health, and specifically, we're going to be focusing on menopause. We're going to talk about what it is, why it occurs, and then we're going to talk about some of the treatments and therapies that can be done to alleviate some of the symptoms. We're also going to talk about some general women's health tips and strategies so that everybody can grow older and feel a little bit better as they do so. We do want to let you know and note that because we are talking about menopause, there will be some discussion of some female body parts. We will be doing so in a clinical fashion with our guest, but we just wanted to let everybody know ahead of time so that there's no surprises. Welcome to Pastoring on Purpose, the official podcast of the Center for Ministerial Care. Join us for this meaningful conversation led by Dr. Tim Manis and the Ministerial Care team about intentionally navigating the challenges, burdens, and opportunities facing church leaders and their families. We exist because healthy churches depend on healthy ministers. The Center for Ministerial Care. For ministers, for families, for you. Welcome to Pastoring on Purpose. I am producer Ryan, and today I'm kind of the host. Joining me today from the Center for Ministerial Care is Lisa Jones. Hi, Lisa. How are you today?
I'm good, Ryan. How are you?
I'm pretty good. And then we're also being joined by Melinda Manis. Melinda, how are you?
I'm doing well. How about you?
Great. All right. And so not from the Office of Ministerial Care, we have a special guest. Joining us is Stacy Flowers, and she is a family nurse practitioner. Stacy, why don't you tell us a little bit about yourself and what you do as a family nurse practitioner so we can get acquainted with you.
I am a family nurse practitioner. Right now I'm working in primary care. I work over here in Cleveland at Direct Primary Care Associates, and we provide primary care on a membership basis. So our office doesn't take any insurance. We are all of our patients pay a monthly membership fee for our services. And in that capacity, the way that I'm able to provide primary care a little bit differently than a way that most people experience that is I'm able to spend a lot more time with my patients. So generally, I'm spending 30 minutes to an hour with a patient in each interaction, which gives me a unique insight to be able to really get down to some root causes of what is going on with people. In medicine today, it's often where providers with the best of intentions are set up for failure and are really only able to talk to people about symptom management without really delving into root causes, without being able to kind of fit puzzle pieces together, even when they really desperately want and need to. And so in my setting specifically, I'm able to do a lot more for my patients. I'm able to provide a lot more encompassing primary care without having to shift everything off to different specialists. Because of that, I do a lot of women's health. In America today, we have our obstetrics specialists that provide excellent care, but because they're providing a lot of obstetrical care, a lot of times gynecological care sometimes doesn't go by the wayside, but not enough time is able to be spent on it. But I'm able to, in my specific setting, kind of address a little bit more women's health issues directly than a lot of people in a primary care setting are able to do.
It's interesting that you're able to spend so much time with your patients, because so many of us are used to being in and out of doctor's offices very quickly, even though we have waited there for 2 hours, right? But the actual visit is like 5 minutes. Mm-hmm. And sometimes I wonder, like, how can you even have any idea what is wrong with me if you don't even know me?
Yeah. And I mean, sometimes you'll have questions in your mind that you want to ask, but by the time you get in there, and again, like you said, it's not really their fault, but by the time you get in there, you forget about your question because you're being kind of rushed through everything.
Yeah, you get so flustered that you've waited for so long, and you get in there and you're in that crunch of, okay, I've got 5 minutes before I'm rushed out. Let me hurry up and get everything in. And even if you make a list of things, sometimes there's not time to address all those things. Sometimes there's not time to talk through how some of those things could all be multifactorial of one root cause.
Right.
And so that's one thing I'm so thankful in the setting that I'm in to really be able to delve deeper into those things and be able to help people on a more personal basis.
Before we take a break, I want to ask one kind of general question about some women's health things, just based on what you've been telling us about the difference in your practice, the way our health system works, right? Where they're brought in and out very quickly and don't spend a lot of time, and it's just a machine churning. Like, do you find that women are affected by that greater than men?
I do. Now, I do think that there are some issues that everyone equally is done a disservice to. But for women, so many of our issues are multifactorial, I feel like, whereas with men, sometimes their issues seem a little bit more straightforward. And, with the things changing in our world culturally and politically, I think that we are seeing it kind of even out a little bit more. But, you women here, I'm sure you can speak to the fact that in this culture, being a full-time working mom is really hard. It's really hard to go to work and work full-time and then come home in the evenings and then still have to be everything to everyone, all while dealing with the stress of, I'm never giving everyone 100%. Men with the best of intentions in the best partnerships generally are not providing the bulk of the child care. They're generally not providing the bulk of the home care. And women, while working full-time, while sometimes being the breadwinner, carry a lot of the mental load. There can seem to be an unequal distribution of responsibility toward the family unit. And I think that because of that, we see a lot of bitterness and resentment and frustration that can kind of build and build and build, and women aren't able to take care of themselves appropriately. They see their children maybe struggling in school, and they know, I can only do so much in the evenings, and I'm at work full-time during the day. My child needs to be homeschooled. My child needs to be in a different school setting, but I can't afford that. I don't have the time for that. I don't want them to have their face in their phone all the time, but they can't stay at home. How can I be everything to everyone? And so I feel like women in our culture today, have kind of been sold a lie that you can have everything. You can have this fantastic career and you can have this, fantastic home life. And women really you don't get to do that. Something is going to suffer, and sometimes it feels like everything suffers. And so I feel like for women, so many times that come into my office, they'll sit and they'll tell me the things that they struggle with. And it really kind of comes down to this multifactorial conglomeration of their life stressors, their health stressors, their lifestyle. And a lot of that can be hard to overcome. And none of those issues usually can be fixed with one thing. There has to be a lot of things that change to fix any one thing. And it can be hard to, after working all day and coming home and being needed all day, evening by your kids, and then you go shut the door to your bedroom and you're needed by your husband. Right. And those things can be hard to have the motivation for self-care.
Exactly. Yep.
We're going to take a quick break, and when we get back, we're going to focus our conversation today a little bit more specifically on menopause and the different sorts of mental health and physical effects that can happen from that. So you're going to want to stay tuned, and we'll be right back. The Center for Ministerial Care provides professional counseling services for Church of God ministers and their families free of charge. We're here to help with marital or financial stress, burnout, depression, loneliness, grief, or any challenge that you might be facing. If you're a pastor in the Church of God who could benefit from professional, confidential counseling with a Pentecostal perspective, we want to help. Visit ministerialcare.com for more information. Welcome back to Pastoring on Purpose. So let's begin maybe just by exploring for a minute, what is menopause? What is actually happening?
In the true menopausal state, that's when a woman has been without a menstrual cycle for a full calendar year. If at any point in that year that your period becomes irregular, you bleed again, calendar starts again at day one. And so you're not considered truly menopausal until you've gone that 1 year without a menstrual cycle. But menopause itself and the whole perimenopausal transition is a time, first and foremost, of hormone fluctuation during perimenopause. And then as you get more toward that actual menopausal state, of the drop-off of the hormone production that your body makes that protects your body. And so as you see those changes happening in the estrogen, progesterone, testosterone levels, you can see a lot of things physically happening to your body that start to change as well.
Why does this occur?
That's how God made us.
Sometimes that's the answer.
Why is it happening the way it does now is a little bit different of an answer. There are so many things environmentally that we are exposed to that are endocrine or hormone disruptors. And that's just the truth of it. There are so many chemicals in the foods that we eat and everything that we put in, on, and around our bodies that is creating this issue a lot earlier for women. And for men too. You know, the data shows that men's testosterone levels at younger ages are hundreds of points lower now than they were decades ago. And I really feel like the science supports that it's a lot to do with all of the chemical exposure that we have in our world today.
Even from my family, I know that we have several that are younger that I personally see struggling with this already. Like it's more in the 30s and early 40s. And, you know, from all the other people that I've been close to that I've watched deal with these issues have usually been much older. So I can see even by them that it appears to be happening a lot sooner and a lot earlier in life.
It does. And some of the biggest things to highlight, a lot of the medications that we take on a daily basis can influence hormone function. A lot of the chemicals, again, in our foods, the chemicals that are in things like toothpaste, deodorant, perfumes, air fresheners. I mean, there's so many things that can inhibit or can alter your endocrine system, your hormone metabolism. And it's hard. You can go down so many different rabbit holes on how am I going to keep myself and my family safe from this.
Right.
And you can drive yourself crazy with it. And at a certain point, sometimes you have to just say, and I've got to live life.
Right.
And so a lot of times it's finding that balance on what are the battles that I'm willing to fight? What are the ones that to me are the most important? And what are the things that I'm just going to have to live and let live and figure out how to, what's the hard I can live with?
Right. Yeah. Gosh, I would have never imagined that perfume. I mean, yes, if I stopped and thought about it, it has all this stuff in it, but I really never thought about it affecting your hormones.
It can. And a lot of that is, you know, the synthetic chemicals that are associated with the fragrance, but also, you know, in the foods that we're eating, the hormones that are used, the preservatives that are used that we often don't think about, and that a lot of times you don't really have. I mean, you can not put on perfume. You can use different kinds of deodorant, but whenever you're at the grocery store and you've got to feed your family, or you're on a fixed income and, you know, you have to make choices that are going to last, a lot of times, you know, it's a lot cheaper to shop from the inside aisles than it is those outside aisles.
Absolutely.
You know, meat, fresh produce, fresh eggs, but those whole foods are a lot more expensive to source than prepackaged things.
Yeah. Yes, my family and I have talked about that too. That it's so expensive to eat healthy. It's crazy, and especially if you don't bring something to work and you run out at lunch and try to find something healthy. Yesterday, I bought a salad, and it did have chicken on the salad and a tea, and it was almost $17. Now that's one day.
That's nuts.
That's one day for lunch. So yeah, if you're not prepared and bring stuff with you that's healthy, you're really out for it to go try to find something in a restaurant.
You are. And, you know, there are ways to do it a little bit cheaper. There are ways to do it a little bit healthier, but it requires so much thought and intention.
And time.
Time. And who has that? You know, but really, you know, and I speaking to myself, you know, as I say this, but if we put a little bit more thought and intention and planning into that, you know, it's definitely easier to make those better decisions, but we just have to get to a point where we're ready for the change. I think, you know, sometimes in our culture today, we want the quick fix. You know, we want the answer that doesn't necessitate any effort or sacrifice on our part.
The magic pill.
The magic pill. Exactly. And I think that we have to get to a point where we're willing to have a little bit of skin in the game if we want to feel better.
And it is a natural process. Even if these unnatural things that are just environmental are affecting when it comes on or exactly how it occurs, it is part of it is the way God made us.
It is a natural process. The change in hormones from a scientific standpoint, of course, our bodies, we're not getting younger. Our bodies are not made to improve with age. Everything degrades.
It's true.
And then on a little bit more of a emotional side, our hormones changing as we age. There's also reason when we're younger and we have that increased estrogen and we have that drive to care for babies and children. And as we age and our priorities in life shift and sometimes our roles shift and our estrogen levels drop, I know sometimes women will say, as I got older, kind of lost that filter a little bit. And, you lose sometimes that drive to be a little bit more nurturing.
You do. Yes. Let's see, example, go to Walmart. I've said so many times that, I remember when I had my kids, I was like so into kids. Like I loved it. It was amazing. And then they got older and they grew up and they're grown and now not so much. It's like, I just don't have the patience and I sure don't have the energy. Like I don't have the energy to even carry around a child at this point in life.
But you have the wisdom. You have the wisdom to be giving these younger mamas advice and the ability to look back and say, okay, these things that I thought were the biggest deal then I can see from this stage of life, those were battles I shouldn't have been fighting.
And Melinda has a house full, I don't know, at all different ages. And I don't know how she has the energy and the drive.
I don't know if energy is what I have. I just know I have to.
Yeah,
I just know I have to do it, and I do it, and crash at night usually.
What are some of the things that a woman might be feeling as they enter this phase of their life?
Metabolically, the decline in the estrogen levels, we can see an increase in central abdominal fat. Even in slimmer women, we can see an increase in insulin resistance, which raises the risk of diabetes. Cardiovascular health is impacted. Increase in your cholesterol levels. You have bone loss, which can increase the risk of osteopenia, osteoporosis. And that starts really before your last menstrual period, the potential to have that bone loss. And again, neurologically, brain fog, increased risk of dementia as those hormone levels change.
How does that affect a person, like just from a mental health perspective? When something bad happens to us, right? Or something is different or there is a change, it can be upsetting.
I definitely think it can be an identity crisis. Whenever you don't recognize your own body anymore, when you don't feel mentally like yourself anymore, you don't know why you're having these hot flashes and these night sweats and you're mad at your husband all the time and you have a lot of less patience with your kids and your coworkers and your temper is on edge. You just don't feel good. You don't have the energy. You don't have the same drive that you used to have. You don't have the same sexual function that you used to have. You don't enjoy intimacy. It's painful. And then, your cravings for junk food increase. You're not getting good sleep at night, so you're always tired during the day. And that's a spectrum. Not all women have those symptoms. And some women, it must be nice to be God's favorite,
Right.
Make that transition very gracefully.
Yeah.
And then some women battle through it. And there's not always a rhyme or reason, but a lot of it has to do with how we take care of our bodies. And I'm in no way saying that women who battle through aren't doing any of these things. But I don't think we a lot of times give enough credit to really the importance of what we're putting in our bodies, the food, the drink that we put in our bodies, how much we're moving our bodies, how much we're putting our bare feet on the ground and getting sunlight, how much that we're giving importance to the quality of sleep that we get, to our stress balance, and then having some type of prayer or meditation routine where we allow ourselves to recenter and regroup and, talk to God, how much grace that we give ourselves, and really having that community of other women that we can talk to and make sure, hey, I'm not crazy, am I? I'm not the only one going through this, am I? And I think that that's one of the things that we've lost in the way that we do life today is the community of women that we have.
Yeah, it's so polarizing because like you said, am I crazy? Like what is wrong with me? Why did I just snap because that cup was knocked over?
It wasn't that big of a deal.
It wasn't that big of a deal. Why do I want to go cry for hours over the smallest thing? So it's a little scary because
it is.
What's going, what's
going on? A lot of that is during that perimenopausal hormone fluctuation where you're having a full tank and empty tank, a full tank and empty tank on sometimes a daily basis. And you have no control over that.
How easy is it to identify that this is a process that's beginning in your body versus being concerned that it's something else? Like, are there indicators or things that someone can be thinking about as they begin to age and are concerned about entering this process?
Yes. So the irregularity of menstrual cycle is oftentimes one of the first indicators, but also the appearance of the hot flashes and night sweats. So those are called vasomotor symptoms. And those are two very hallmark things that we know that are associated with menopause, that are outside of the other, and I'm not saying they're not important symptoms, but the hot flashes and night sweats right now are the only FDA approved uses for hormone replacement therapy. So those are the kind of the things that are focused most on. Not at all to say that those are the things that most people have issues with, but hot flashes and night sweats are of course some of the hallmark signs. We know that the most common ages for the perimenopausal timeframe is between the ages of 40 and 50. Number one, it's becoming much more of a conversation now. I think that's important to note. So it's women, I think, are a lot more in tune now than they have been in decades past. And I think that that's really important. And I think that's a really great stride that we've made as a medical community. 2 decades ago, there was a trial that came out by the Women's Health Initiative, or a study rather, that created a lot of fear regarding hormone replacement therapy. And so for women, that was, for the last 2 decades, something that we've just been kind of told, hey, this is just a normal part of life and of aging, and just get used to it. This is your new normal.
Just get through it.
Exactly. Yeah. And we were told that not just by our spouses, but by our doctors, by not just our primary care doctors, but by our obstetricians and gynecologists, by the urologists. We were just told this is your new normal. And the reason was because when that black box warning was created and we were told that there were these risks associated with hormone replacement therapy, it felt like there was nothing you could do about it. And so we know now that that's not true. But for those last 2 decades, largely providers in all specialties have not really been taught a lot about hormone replacement therapy. And so it really felt like there wasn't a lot that you could do about it unless you had been given specific specialized training that you a lot of times had to seek after school, because we're not really taught these things in school. I went to nurse practitioner school 7-ish, 8-ish years ago, and we're not taught anything about hormones for men or women. And so if that's not something that you're seeking education about from a provider standpoint, you a lot of times don't know how to help people through it. And so a lot of times, I'll have patients come in and they've done the research on their own, and they maybe know a lot more about what's going on with them and kind of what direction that they want to take treatment options, more than I do sometimes. And that's something I'm very open to, and thankful that women are doing that research and that hard work for themselves right now. And very thankful that the tide is changing and that hormone replacement therapy for women is becoming something that's a lot more common, as long as it's done safely. But more back to your question, yes, just having those vasomotor symptoms, having the changes in mood, but again, saying that it's multifactorial, it's really an unrealistic expectation to be treating your body like trash and think that you can take a pill and it change if you're not willing to change anything about your lifestyle. And so it can be really hard as a provider to pick through negative lifestyle to get to the root of what's going on with somebody. And so when people come in with issues, some of the more overt things like the menstrual irregularities and the vasomotor symptoms, there's things that we can kind of pinpoint is we know exactly what these are. And then everything else, we have to have a conversation about how you're treating your body. What are the things that are going on in your life that can be contributing to this? And there are labs that we can do to kind of see where you're at in this spectrum of hormone production. But it's a lot different of a discussion with a pre or perimenopausal woman than it is with a postmenopausal woman. That's a lot more cut and dry in how we're going to deal with this. And in the perimenopausal setting, it's a lot more complicated.
You mentioned a couple things that kind of struck me. I'm glad that you mentioned that just as like general learning, you're not, taught that, because like for 2 years, I kept asking my doctor, and I love my doctor a lot. He's great, but I think I'm maybe approaching menopause. He's like, well, let's do blood work. Well, the blood work is fine. And, for everything, there's a range of blood work, but if I'm not below what I should be, then you're fine. What are you going to do? Like, so for a couple years, and then finally, like recently, it's been like, oh yeah, you may be getting there. And I'm like, oh, okay. I've also you hear things. So I've heard there's like a time when the blood work will be more accurate. Is that a thing really? Or
that is true. And for a perimenopausal woman, that can be really, really hard to nail down.
Right.
Because again, I'm in a primary care setting. I do not pretend to be a hormone specialist. Mm-hmm. And if there is a woman that comes to me and feels assured and she is a regular menstruating woman that she is having hormone issues and her labs are normal, I'm going to encourage her to see a hormone specialist or her OBGYN who knows a little bit more specifically, because whenever you're checking your hormones at the beginning of your cycle, at the end of your cycle, it's showing different things.
Right. I guess that's what I was trying to get at.
It's showing different things. For a woman that's perimenopausal, and with all of the things that are available today, we may have these women who have had an ablation, so they're not necessarily menstruating, or they have an IUD or an explant or whatever that may mess with their ability to menstruate, so they don't really know where they're at in this cycle. I do want to speak to quickly that one of the things that's becoming a lot more accepted to do in the perimenopausal stage is treating with testosterone. That's one of those things that's a little bit more straightforward. Mm-hmm. That we know a little bit more about in perimenopause as opposed to treatment with estrogen and progesterone. And so that's something that can kind of, you can dip your toe in with that a little bit easier sometimes and do that with a little bit less concern that you're going to create undue risk in a woman who is still creating her own hormones if we can see that her testosterone levels are low. Because that's one of those things that you're probably going to feel. You're probably going to feel that decrease in libido, that decrease in sexual function, that decrease in energy, that low dose testosterone hormone replacement therapy in perimenopausal women can work. Now, again, there are some circumstances in which replacing estrogen and progesterone is also needed, but in those younger women, that can sometimes be a good first place to start. It's also not a realistic expectation to think you can go into any primary care setting and receive this type of care. Right. It's just not going to happen, again, because most people aren't taught about it. And so if you're going to your provider and you're not getting anywhere, there is nothing wrong with asking for a referral to a specialist. And, even if you go see a specialist and you don't get the answer that you're looking for necessarily, it's not a realistic expectation a lot of times as a regularly menstruating woman or as a perimenopausal woman to think that you can go into a primary care setting where they don't have the education to make these decisions for you and think that you're going to get the type of assistance that you'll hear people talking about on TikTok and Instagram. And it's just not a realistic expectation. They don't know how.
Yeah.
What is the specialist they should ask for the referral for?
Well, an OBGYN or an endocrinologist. An endocrinologist also is going to look, because not only, especially in perimenopause, but in menopause as well, you need to look also at thyroid function with people who are having these crazy thyroid things that can be causing, or the way that their thyroid is interacting with the hormone levels. This a lot of times does need specialist care. In defense of primary care providers around the world, a lot of those things, it's not a realistic expectation to think that you're just going to walk in off the street to a regular primary care office and they're going to know how to deal with those zebras. We know how to deal with the horses with hoofbeats, not always the zebras.
I would imagine that you see a lot of ladies that come in that are possibly in this period of life, but maybe don't, they have been told by this doctor or that doctor, no, everything is fine. That at that point, maybe they think that they're having anxiety or they're having, some sort of emotional or mental type issue. Do you see a lot of people that come in and are just like at their wits' end that feel like now they're going to have to go on anxiety medication because they can't get any other help?
Yeah. Oh, yeah. We'll see women that have those issues or think, oh no, am I starting the beginning stages of dementia? I'm having so much brain fog. And that creates a big fear for women, and that brain fog that's associated with, one, poor lifestyle and insulin resistance, but two, with hormone changes can really be debilitating. And so whenever you're not getting answers as to what this could be or what your options are, because we know that with the good that can come out of anti-anxiety, anti-depression medications, the side effects that can come with them can create bigger issues. And so if you come to me and you're having a lot of anxiety and I put you on this anti-anxiety medication and then it makes you gain 20 pounds and you don't want to have sex with your spouse anymore, I've helped one problem and created two new ones.
Right.
And how is that really going to help your mental health long term whenever I've just given you a body image problem and a marriage problem associated with it?
Should every woman be going through this with their doctor in some capacity, or is there a sign or something that is like a red flag that they should then involve their physician?
Symptoms that are impacting quality of life are always a red flag to see your provider and talk about what can be done and what are the realistic, most safest options. The things that we know now about menopause and about hormone replacement therapy, it's a little bit easier of a discussion to have about that risk versus benefits. However, it's important to have a discussion with your provider with your specific symptoms and your specific health issues and comorbidities as to what is appropriate for you. And so women that may not be as much of a candidate for hormone replacement therapy associated with menopause are going to be your women that have had a history of estrogen-driven cancers or a history of heart attack or stroke, a history of blood clots. And we do know a little bit more nuance about those specific things that I won't get into today, but that's why it's really important to talk about your risk factors, your family history with your provider, along with how severe your symptoms are. And then you have to pick the risk that you're willing to take. Not to say that the risk is great for your average person, but for those individuals, your risk would definitely be greater. But we do know now that hormone replacement therapy that started early is actually protective to your heart, protective to your bones. It can reduce cancer risk. It's protective to your brain. But the importance is that it started early. And that's what's really important about more women knowing about it, because once you're in your 60s, that's not really the time to be starting it brand new. Right. There is, and we need more studies. This is the black box warning being removed just happened this year. So we need more studies. But what we know right now is that there are more risks associated with starting it after 60 than starting it early. And so it's important for women to start having this conversation with their providers before they've dealt with symptoms for 10 years. Whenever you're starting to feel these changes and you're still menstruating, it's a good idea to have a discussion with your provider, either with them directly or ask to be directed to someone who can have a more informed conversation about it. But then in the primary care setting, it's a little bit more realistic to have an expectation, or in your basic OBGYN office, that you're going to get menopausal hormone replacement therapy. That's a little bit more cut and dry, and the discussion is a lot more easy in that age group. It's important to note that topical or transdermal therapy carries a lot less risk than oral therapy. And vaginal estrogen is something that's safe in every stage and for every risk, because it's not getting systemic absorption. You're getting that absorbed topically, and most topical therapies of estrogen and progesterone that are for systemic absorption aren't reaching the vagina. And so a big thing that we're seeing in women perimenopausally and then also in overt menopause is pain with intercourse, vaginal dryness, irritation, frequent UTIs. And that's something that the frequent UTI portion of it can really impact not only perimenopausal, postmenopausal women, but then in those last few decades of life, if you think about women that you may know, elderly women that are getting these frequent UTIs who end up in the hospital, who end up in the ICU or on life support because they've gone septic over these UTIs that maybe they thought were just confusion or just, this or that. And it took them a while to realize this was a UTI. And so the protection that can be provided by vaginal estrogen therapy is just really invaluable. I was listening to a podcast by Rachel Rubin, who is a menopause specialist urologist, and she was saying that if we could put every Medicare age woman on vaginal estrogen, aside, of course, the most common reaction there or side effect that you're going to have is a localized discomfort or localized reaction. And so, those women aside, but if we can blanketly put women as standard of care on vaginal estrogen therapy, the millions and millions of dollars that we would save Medicare in the reduction of UTI treatment would be astronomical because of the protection that we can give women who, and so that's another thing for women to think about is if I'm getting frequent UTIs, if I'm perimenopausal, if I'm menopausal and I'm getting frequent UTIs, my first thought should be vaginal estrogen, not I'll be okay with taking antibiotics several times a year. We should never be okay with taking antibiotics several times a year. The way that one course of antibiotics destroys our gut bacteria and can completely change our gut microbiome, we should never be okay with that being the norm, that we just randomly have UTIs multiple times a year. And that should be one of the first things that we think about. And tell your friends and tell your moms and your aunts, you need to be thinking about vaginal estrogen if you're someone who's having frequent UTIs. If you're having pain with intercourse, do not let anyone tell you that's normal. That's just your new normal. Use some lubricant. You need to be having a discussion with your provider about the appropriateness of vaginal estrogen, of vaginal DHEA. Pain with intercourse is not a normal part of the aging process. We have things that we can do about that now. We treat women so differently going through these hormone changes than we treat men. If we think about how many products there are on the market to help a man get an erection, if we think about the way that men are supported through hormone therapy and how many places that are around town that men can get testosterone therapy and how hard it is for women to seek care, it's not fair. It's not fair that there's a difference in the quality of care that's given and how women are told that things are normal and that's a new stage of life and you just got to suck it up and deal with it, while we're these same women that we're not giving vaginal estrogen to, we're giving their husbands Viagra. I mean, that's creating these marriage problems later in life where you have couples that are still wanting to be active and yet, we're helping the husband and we're telling this wife, go rub two sticks together and hope for the best. And that needs to change.
I love that you're speaking on having a conversation, not only with your doctor, but with the females in your life around you. I feel like up until even recently, for so long, it was just keep it quiet. We don't talk about those areas. We don't talk about those feelings. As a woman, you deal with it. You have other people to take care of, but know your body, and they're, probably people dealing with the same thing. It's not a dirty word. It's not a crass topic. Have a conversation. It's okay to have that conversation. And
we should be okay with having those conversations with each other. And that's the importance of finding that community, that trust among women where we're able to talk through these issues that we're having. And if you were able to fix an issue, please help me so that I can fix it. But also to have a provider that you trust enough to have these conversations with. The number of women in my practice that are never going to tell me that they have pain with intercourse, that they have vaginal dryness, that they're not able to achieve orgasm anymore, that it's a marriage problem in their 50s and 60s because they don't have the desire to be intimate with their spouse the way that they used to, it's very hard for a lot of women. In that generation, I'm 41, but and it's still kind of hard for me to talk about. But women in their 50s and 60s and 70s, I mean, you have to ask them.
Right.
They're not going to tell you if you don't ask them. And so when I see women, a lot of times I'll go ahead and bring it up. I'll go ahead and bring it up. It's a part of, I have a hormone questionnaire. If someone comes in and they're wanting to talk to me about hormone replacement therapy or just hormone symptoms, I have them fill out a questionnaire and it lists 20 plus symptoms that can be associated with hormone dysfunction. And those things are on there because I don't want them to be scared to bring it up or feel uncomfortable or feel like those are things that are taboo and maybe she doesn't feel comfortable talking about it. And so I'll lead that conversation. But having that provider that you feel comfortable with that will be proactive, but then having, your sisters in Christ, your family, that you're able to have honest discussions that you're not going to feel judged or dirty. I think
or
a lot
embarrassed
of times, embarrassed.
even,
I feel like a lot of times, in conservative Christianity, we're really, really good about telling our women how they need to be pure before marriage, and we don't really educate them on, now that it's okay, how to have healthy conversations about it, how to speak up for yourself and how to talk about what you need, but also whenever you're hurting, whenever things are uncomfortable and painful and things that something can be done about, you shouldn't just be okay with it hurting.
We have just now seen, I think, over the last few years, a change in the stigma that has been placed on therapy or counseling. And I guess really because of the office that we're in and the kind of counseling that's done here, I've really never thought about how that carries over into that generation of women mostly going to their doctor and asking for help about these types of issues. And, really, I guess it's kind of all the same. It's just now getting to the point where people are more open about having counseling, letting people know they're having counseling, not being embarrassed to have counseling. And so hopefully it will get to that same place with these types of medical issues that women need help with. It shouldn't have to be embarrassing. And that is, I think, something that's going to have to be broken by giving people the right information and letting them know that they're not alone.
Whether you're a man or a woman, I think anything involving those private spaces feels very personal and embarrassing when there are issues there. Right. And your doctor should be a safe space to discuss those things. And I know one of the things like my wife has struggled with until recently, because she's got a great practitioner now. I'm not going to mention any names, but she's on the show today. But one of the things that I know that my wife has talked about with me is that, like, for many, many years, when she had a problem that was probably a female problem, she was always told, well, the issue is you need to lose weight. Like the dismissive just answer that most of the doctors she's ever seen have given her. And then the other thing is that she kind of grew up in a world where the person that you talk about those things with is your mother. But there are 2 decades of medical advances and knowledges between what her mom went through when she had these changes and what she is beginning to go through as she has them. It's a lot of difference, right? And so I think it's really important not just to have others that you talk to, but also to be aware that you're talking to people who are in the same general kind of generation as you, so that you're not comparing, completely different experiences because of technological and medical differences.
I think that's very valid.
I know myself, over this last couple of years, I have dealt with a weight gain that no one has explained. Nothing has changed. My eating habits haven't changed. I've even been trying to walk more and be more physical, which has been hard because I've had a couple of back surgeries. So it makes it a little more difficult to do certain things that I know I need to do to work on certain areas of my body. But I've had so many doctors, and I've asked so many questions, and it all has come down to, well, you need to lose weight. They don't delve any farther. Like it all boils down to, well, you're going to have to watch your diet. You're going to have to lose weight. You're going to have to be more active. Not only one doctor, but I can tell you probably at least 4 to 5 that I've seen in the last 2 years that have said the same thing without digging any further. It is very frustrating, and it is very emotional. I know for me, like, I don't want to see a picture of myself. I don't like to be in front of a crowd. Like, I would just rather, blend in because I can't seem to get anywhere with it. So it is very emotional, and I think very mentally frustrating, and I won't say depressing. I'm sure for some people it's depressing, but it is very hard to hear that over and over when you keep going and you keep asking and you want answers and you want to do what you need to do, but they just, they kind of stonewall you. So I don't know. The answers are hard. And I guess it comes down to being more direct and making sure that you say, I want to be referred to this person. I want to be referred to that person, and speaking up for yourself.
Yeah. And there are a lot of things positive that have come out of GLP-1s, the weight loss medications that are available right now. And I've seen those do a lot of good in my practice. There's a lot of negative stigma associated with them as well. And there are some people that they just plain do not work for. We know that there is information out there, studies that show that actually hormone therapy and GLP-1 therapy really work synergistically very well together for a lot of menopausal women. Because so much of that menopausal state, like I had mentioned earlier, is insulin resistance and can predispose you to insulin resistance. And so working on both sides of that really can help to improve. There are ways that our bodies change, that they're meant to change during that menopausal state that no hormone therapy is going to overcome. And metabolism is one of those things. Our metabolisms just change and our body distribution changes. And for some women, there's a lot of genetic component to that. If the issues that you're having with your body at a certain age are the same issues that every woman in your family's had with their body at that age, that can a lot of times be a lot to overcome.
Right.
And it can sometimes not be as simple as there's this hidden blood panel that if somebody just knew this one hidden blood panel to do, that it would unlock this new door. And so that can sometimes from the provider standpoint, it can feel helpless on our end to say, and I don't know what else to do for you. I don't have any more answers. I take that personally. When I don't know how to help somebody, that really bothers me. And I really take that personally. And I worry about that whenever I know that I have not met a need or an expectation that I know that someone has. And I think that the most important takeaway is for a person to make sure that all the things that they have control over, that they're doing their best for that, because you can out-eat any amount of diabetes medication. I always say that to people. Right. You can out-eat any amount of diabetes medication. But
why did you just look at me?
Say it louder for the people in the back. But you can out-negative lifestyle any amount of medication, any vitamin, any supplement that you take. When you look at the spectrum of what are the things that I have control of in my life and how much is the needle going to move with each of these things individually. With vitamins and supplements, the needle's going to move a little bit. With medication, a lot of times the needle's going to move a little bit. With lifestyle modifications, the needle can move quite a bit more and can work synergistically with medications, with vitamins and supplements to create a much bigger change than it. And I'm not saying that you weren't trying to do those things, but it's really important to make sure that all of the things that you have control over, that you're being very intentional about those things, that you're taking care of your body well. And then whenever you still aren't getting the answers, that you are presenting your provider with the clearest picture of of how to dig through the weeds to find actually the pathology that's underlying, because it's really hard to pick through the pathology when you're having to delve through a lot of negative lifestyle and the consequences that are associated with that on top of pathology.
If you would like to help support the Center for Ministerial Care continue its mission of serving those who so faithfully serve all of us, we encourage you to like us on Facebook, subscribe to this podcast, and share it with others. You can also visit our website at ministerialcare.com and click the donate button to make a contribution that directly benefits our services.
What are some lifestyle changes that aren't medicine based that could help?
I'll start with some natural supplementation. So amberin, black cohosh, ashwagandha, anything in your adaptogen realm, which is going to help reduce cortisol levels and provide adrenal support. Those are all going to be things that can be positive. Vitamin supplementation, I like a good methylated multivitamin. Vitamin D supplementation is so important to help your body be able to process the calcium that you take in. I really like a good D3 with K2 and an omega-3. If I am going to tell anyone, but especially a woman in those peri and postmenopausal years, if you're going to do any vitamin supplementation, the ones that I would absolutely have in my arsenal would be that omega with DHA and EPA, a D3 and K2, and a methylated multivitamin. And then aside from that, remembering that food is either going to heal your body or hurt your body, and there's not a whole lot of in between. And with that, people are having to pick the hard they can live with a lot of times because, we're in the South, and, food is community, and food is entertainment.
Olive Garden is family?
So there's a lot of our interaction with our peers that's associated with food. And so we're going to have to get to a place where you find what's your happy medium between being restrictive and healthy and allowing yourself to still have that community. We know that the things that are going to promote systemic inflammation in our body is everything processed sugar. Processed sugar is going to feed cancer, it feeds infection, and it promotes systemic inflammation. And so anything that we can do to, one, reduce the calories that we drink is going to, for a lot of women, make a big difference. The sodas, the teas, the energy drinks, the everything processed, prepackaged, canned, the teas, all of that, not like an unsweet tea, but sweet tea, all of those. Anything that we're drinking that's creating an insulin response in our body is not good for our body. And your blood sugar is going to spike more from liquid sugar than it is from sugar that you eat. And so I would say really, don't drink your calories. You have a lot more calories for food if you're not drinking your calories. Then also as much whole food as you can get, meat and fruits and vegetables and cheese and eggs, and try as much as is possible to stay away from prepackaged chemical-laden food. Dairy, for a lot of people, is going to promote inflammation inside their bodies. And then gluten for some people. Now, a lot of that is related to the trash bread that's in the store that is bleached and enriched and covered in chemicals and has zero nutritional value. And so if you have someone that you know in your life that's making bread from non-bleached, non-enriched, or milling their own grain, or something where you're getting grain that has actual nutritional value, that's going to be a lot better than the bread that you're going to buy in stores. High carb meals that have no protein are awful for women. So increasing our protein intake and reducing our insulin resistance by reducing the amounts of those just high carb, non-nutritive foods that we're eating. As women with insulin resistance, we're probably going to feel a lot more impact again with our hormones than maybe a man necessarily would. Not that it's not going to affect a man just as bad with their overall health, but just the way that all of that goes together for us, we're going to probably feel that a little bit more. And then just making sure, again, that we're moving our bodies. And that doesn't have to be high impact exercise. That's walking. That's how are we creating bodies, especially through those perimenopausal years, that are going to carry us into those later decades of life where we can be mobile and independent for as long as possible. How are we going to create a body that's going to still be able to clean house and cook food and drive, and that we're not going to need our kids to come and take care of us? Right. Or, and for those that don't have that family support system, that are going to then have to have help of some kind, and then how am I going to afford that help? And so those things matter now. You can't wait until you're in your 60s and 70s and 80s to say, oh, okay, I need to build some muscle mass and create some bone density.
Right.
That's the decisions that we're making for our bodies right now that are creating the body that we're going to carry into those later years. And how we treat our bodies now creates that bone density and that muscle mass. And so resistance exercise, even if it's things with our own body weight, even if it's some air squats, some wall push-ups, some resistance bands, getting a weighted vest, anything that we're doing that's creating resistance that doesn't have to be this high impact exercise is going to help our bone density. Everything that we're doing cardiovascularly is going to help our heart. And if we can maintain muscle mass and bone density and flexibility, we're going to create bodies that are going to carry us into those later years with a lot more independence. I'm sure we've all seen people, they get older and they just kind of sit down and they're kind of done. And they're not as mobile and sedentary, and they're just kind of eating whatever. And if you don't use it, you lose it.
Well, thank you so much for spending the time with us, Stacy. This is some great advice and also some wonderful information about just what is happening with our bodies, as we age. And it's been a real pleasure to have you on. And I know that our listeners are going to find all of this to be very valuable and are going to go vitamin shopping.
Thanks for having me. I really appreciate the opportunity.
It's our pleasure. Well, until next time, on behalf of our guest, Stacy Flowers, and of course, Lisa Jones and Melinda Manis, and myself, producer Ryan, we'll see you next time on Pastoring on Purpose. God bless. You've been listening to Pastoring on Purpose, the official podcast of the Center for Ministerial Care. Join us next time as we continue our purposeful progress to becoming better pastors and better people.